First of all, I'd like to thank you for the invitation for the opportunity to speak today. My topic is redefining in vivo and in vitro diagnosis of Hymenoptera venom allergy. I'm a resident of dermatology in the Department of Dermatology at the Medical University of Graz in Austria, and I do a little bit of scientific work in the field of Hymenoptera venom hypersensitivity under the guidance of Professor Sturm. So, first of all, my conflicts of interest, nothing special. I'd like to have a few words about Hymenoptera venom allergy first. Hymenoptera stings are very common with the general population, stating that they've been stung once in lifetime in 56.6 to 94.5% of the general population. In Northern and Central Europe, the most relevant species are the honeybees, the Apis mellifera, and the yellow-jacket wasp, Vespula germanica and Vespula vulgaris. Also, there are, in lesser cases, bumblebees, as well as hornets, and in Southern Europe, Polistes. Hymenoptera venom's hypersensitivity is a major cause of anaphylaxis in adult patients, with 48.2% of anaphylaxis in the European anaphylaxis registry being contributed to that. In children, it is a little bit less. There's approximately 20% of cases of anaphylaxis due to Hymenoptera stings. The lifetime prevalence of a systemic sting reaction varies from study to study from 0.3 to 8.9%. Also, what I often see in clinic is that it really negatively influences the life of the patients. They're afraid, they don't want to go out. In Austria, people like to go to the mountains. There are beautiful mountains here, and they often ask, and what should I do if I've been stung? I don't know, at 2,000 meters altitude. Should I call the helicopter? What should I do? And this is really an important matter for them. So how do we diagnose Hymenoptera venom allergy? First of all, it's the patient history. Afterwards, we do a skin test, an IgE measurement of specific IgEs against the venom components, and as well as a basophil activation test. First, I'd like to have a few words about the patient history. It is very important because this little bee can sting, of course it can, and it can do a normal reaction, it can do a large local reaction, and people don't understand that a large local reaction isn't a allergic reaction. They come to us, I had a reaction, and you ask them, yeah, it was just swollen. And then there is the real anaphylaxis with flush, chest tightness, throat tightness, vertigo, nausea, emesis, and cardiorespiratory reanimation. Why is that important to differentiate? Because if you do serological tests on patients with normal reaction or large local reactions, they can be positive up to 40%. And this is important because our Professor Sturm published a study 2012 where he stung 133 asymptomatic serologic positive patients. And it was seen that a serologic sensitization is a risk factor for a large local reaction, but not for a systemic reaction. If you take it in comparison, it was 6 times or even more, 8 times as likely to have a large local reaction after a Hymenoptera sting, while the systemic reaction burn significantly increased. The control data was from a telephone study in which we asked patients if they had a large local reaction or a systemic reaction. Then there's another pitfall, which, in my opinion, we're told since childhood that if a bee stings, the stinger is left inside. This is also beautifully seen after a sting provocation we did at our clinic. But if the wasp is under pressure or being pressed, example given with our arms to the torso, she can also leave the stinger inside the skin. And it is important to differentiate if the patient gets one treatment, both treatments. So the diagnosis is pretty important, because we can cut costs if we don't do both venoms, and also the adverse events in the build-up phases differ from bee venom and wasp venom. It is up to 6 times as likely to have a systemic adverse event in the build-up phase of a bee venom immunotherapy in comparison to wasp venom therapy. We made a publication in 2020 where we compared retrospectively about 500 to 600 patients at our clinic and found out that the double venom immunotherapy isn't associated with more systemic adverse events as bee venom immunotherapy. The next part of the diagnosis is the skin test. The prick test, I must admit, we don't do it that often, but it is done in concentrations of 10, 100, 300, and 300 micrograms per milliliter. It is read 15 minutes afterwards, and a positive result is the wheal of 3 millimeters. Intradermal test is, in my opinion, better because it is also more sensitive. It is done in concentrations of 0.01, 0.1, and 1.0 micrograms per milliliter. One can also start a little bit lower. I've talked with colleagues from Germany, and they told me that they also do lesser concentrations. There are different opinions in how to make the intradermal test. The first one is in ascending manner. That means we only do one concentration of bee and wasp venom at a time and see at which point it reacts, or we do all simultaneously. We prefer the second option, as we do our 6 concentrations simultaneously, and we've seen that it is safe and efficient. In this case, a positive reaction is a wheal of 5 millimeters or more. The next point is our IgE measurements. It is the detection of specific IgE to venom extracts or venom molecular agents. As you all know, the threshold is 0.35 kilunits per liter. And what's also very important to keep in mind is that specific IgE has to be in correlation to the total IgE. Namely, if you have an atopic patient with high total IgE levels, the results could be false positive. Or otherwise, if you have someone with very low total IgE levels, they could be false negative. The next thing we have to keep in mind in IgE measurements is that in vitro double sensitization is found in approximately 25 to 40%. This is due to true double sensitization, asymptomatic sensitization, as mentioned earlier, CCDs, these are antibodies against glycosylated parts of the venoms, and venom cross-reactivity. In our data from 600 patients, we've seen that the IgE levels have very good sensitivity, especially if they're adapted in case of a low total IgE level. This means the specific IgE against bee venom extract is 94.6%, and against wasp venom extract 97.0%. If you look at the allergens now, there are 12 bee venom allergens. The sensitization against them is very uneven. In this table from Bilo et al. In 2090, at APM1, the sensitization rate goes to 97%. This was in a first study, and the studies which followed had a much lesser sensitization rate from 57 to 70%. In our case, the sensitivity of all available molecular components, this is APM1, APM3, 2, 5, and 10, was together 68%. The next thing we have to keep in mind, I mentioned it earlier, are the glycolated parts of the bee venom allergens. The red asterisks here represent the venom allergens who have those glycolysated parts, and these are 80% of all of bee venom allergens. And this is important because if you look at a IgE measurement in Fadia example given, we have the allergen, the antibodies against the bee venom, and the blue ones are the antibodies against the CCDs. In this case, the worst scenario being the patient has a high total IgE level. He has no specific IgEs against the venom components, but only against the CCDs of the venom components. If you look at the wasp venoms now, there are fewer allergens, and they also do not have CCDs. If you look at the same publication from Bilo from 2019, the sensitization rates to VESV1 and VESV5, which can be done routinely, was 33 to 50 and 84 to 100% respectively. In our data, it was for both combined approximately 88.5%. Next thing I would like to talk about is the potential cross-reactive allergens. There are hyaluronidase in both bee and vespid venom. There are dipeptidyl peptidase 4 in bee and vespid venom, as well as vitellogenin. But the homology of these venom components is only about 50%. So it is doubtful or questionable if it causes cross-reactive results. The next thing, which is getting popular in Austria, is multiplex allergen testing. And we did a poster for the IACI 2020 with the ALEX2, in which we took 50 patients from our database and compared the sensitivity of the multiplex allergen test with the common methods. If you see now the orange, that the combined sensitivity of the ALEX was 71%, and the bee venom extract was at 88%, so it wasn't very good. If we compare it with wasp venom, we see that the ALEX compared much better. So we concluded that it is sufficient for the diagnosis of vespid venom. The next thing we should do and don't forget about is tryptase. Tryptase is a serine protease that is primarily produced and stored in mast cells and less abundantly in blood basophils. It should be taken routinely in any person who had an anaphylactic reaction, and the normal values range up to 11.4 micrograms per liter. Increased baseline tryptase levels are suspicious of systemic mastocytosis, especially if they are higher than 20 micrograms per liter. This is a publication from Valent et al., the Austrian perspective to mastocytosis, and he suggests that if there is a serum tryptase less than 15 nanograms per milliliter, we should follow up. If it's between 15 and 30, we should as well do genetic testing. And if it is over 30, we should do additional studies. I would like now to present how we do our approach. We take a detailed history of anaphylaxis, gastrointestinal or psychological problems, non-steroid inflammatory drugs intolerance. Then we look at the skin for signs of cutaneous mastocytosis. This is a little bit easier because allergology is done by dermatologists in Austria. I'm not certain how it's done in Greece. Then we do the genetic analysis for the KIT mutation D816V. And then we suggest for the patients, if the tryptase level is under 20, they should do a yearly checkup with ultrasound of the lymph nodes and abdomen. If it's over 20, we also do a bone marrow biopsy and osteodensitometry. Then if the mastocytosis is diagnosed, every patient should get an emergency kit. This is for Hymenoptera venom patients in no problem because they already have it in most cases. And we suggest that they should avoid histamine liberations in case of cutaneous mastocytosis. Physical stimuli, if somebody has urticaria pigmentosa and he's being massaged, it could lead to a massive amount of release of histamine. They should be wary of medications such as non-steroid inflammatory drugs, opiates, radiological contrast media, and we suggest that they should have a preoperative medication with H1 and H2 and antihistamines. Next question, which pops up in Hymenoptera venom allergy is, how long should a patient with mastocytosis have Vespid venom immunotherapy? The last guidelines I haven't found any data on this matter, but they suggest that it should be prolonged due to safety reasons. And in our clinic, we usually give it lifelong if the patients are in compliance with that. The next test I would like to show is the basophil activation test. It's an in vitro diagnostic tool which imitates the activations of basophils in vivo. I would like to show a video. This is how the test works. These are the basophil granula. The allergen binds to the Fc epsilon Ri receptor and causes the degranulation of this granula. And those small purple receptors, CD63, can then be measured with flow cytometry. This tool is useful for diagnosing patients with negative IgEs or skin tests, or in case of double sensitized patients. In our database, we have 637 BAT values, and we have found that BAT has a sensitivity of approximately 73% in bee venom and 84% in wasp venom, and a specificity of 58% in bee venom and approximately 83% in wasp venom. The next question is the efficacy of Vespid immunotherapy. It is very efficient. The data shows from 80, 77, 86% in bee venom to even more in Vespid venom. And a colleague of mine, Dr. Schrautzer, published a study into 2020 where we assessed the efficacy of BIT 1 week after reaching maintenance dose, and 71 from 71 patients tolerated the sting. But for me as a clinician, there's an important question. How do I how to identify the patients who are BIT failures? The available method right now is a sting provocation with living insects. This is a method which could lead to a possible anaphylactic reaction. It has a high personal input, but may improve patients' quality of life, because people who are afraid and see that after they reach the maintenance dose, they don't react anymore, they often say to me, it's really, really easier now. One thing to keep in mind is that it kind of depends on the weather. This means we cannot do sting provocations from January to June, because often the insects don't fly in that time. And the other question is, we have to catch them. But if you have very inventive colleagues, such as we have, they could make a homemade insect catcher out of a hand vacuum cleaner. Functions very, very well. So how do we do our sting provocations? We admit our patients to our day clinic. In the morning, they should not eat on that day. They are being cardiorespiratory monitored. They get an IV line, and then we give the insect in a double chamber syringe on the non-dominated forearm. We put the insect on the skin, and we have to a little bit annoy it with the tweezers so it stings. The sting should last over 20, 30 seconds, and afterwards we can see in that case the bee stinger stays in the skin of a bee venom sting provocation or bee sting provocation. But as I mentioned before, this is a potential risk of heavy anaphylactic reaction, so there should be other ways how to measure the effectiveness of WIT. And this is in case possible in the case of IgE. IgG4 is a subtype of IgG, which is related to inducing immune tolerance and reducing the inflammation. We found that in persons getting bee venom immunotherapy, the IgG4 levels are 96-fold higher, and in West venom immunotherapy 46-fold higher. We were looking now for a threshold in which we could say the patient has an effective WIT or non-effective or is a treatment failure, and we were searching for a threshold value. We found the threshold value for bee venom at 2.4 milligrams per liter, but in this case, the sensitivity was only 75%. It means every fourth allergic patient would be under-treated. In West venom, the threshold was given at 6.6, and there we could see a sensitivity of 91% and 93%, so much, much better. Next possible method how to measure tolerance is due to the enzyme-like facilitated antigen binding. First, we have to take now a look at the facilitated antigen binding, what this actually is. This is a method in which we mix the indicator serum with a specific IgE of more than 100 kilounits per milliliter with the test serum and allergen. Then we incubate this, add B cells to form an antibody and allergen complex, wash the B cells and stain it with an anti-IgE fluorescein, and then we can analyze this by cytometry. Since B cells are relatively hard to culture, there is a other way. It's called the ELIFAB, the enzyme-like facilitated antigen binding. We have the CD23 binding antibodies, and in case of normal allergic patients, the cross-reactive IgE antibodies bind to the CD23. There comes a subsequent bind IgE antibody and an enzyme which can then be measured by ELISA. If there are binding antibodies, this cross-link does not happen, and we cannot measure the ELISA. ELIFAB as marker of efficacy. We also set a threshold which was not very good, but again, as in bee venom, it was better in West venom. Now I would like to go to some bat examples. This is how it looks like in our lab. If we have a bee venom allergic patient, the bee venom increases. If we have a wasp venom allergic, wasp venom increases. And the flow cytometry, if both is negative, we only have the IgE control, and approximately 10 to 15% are non-responders who cannot be evaluated by BAT. Another tool we did, which is kind of promising in our opinion, is the BAT inhibition. There we put the basophils of patients with Hymenoptera venom allergy with patients treated with venom therapy, and we see a much decrease in basophil activity. In bee venom, it was a slight decrease. In the wasp venom, there was a high decrease of BAT activity when incubated with a patient who tolerated the sting provocation. Two patients who did not tolerate the stingration showed no decrease in basophil activity. I would like to conclude with a beautiful diagram, Arts et al. Published 2019, how to diagnose Hymenoptera venom. We do a prick endodermal test or serum IgE. If it's single positive, we do the respective venom. If it's double positive, we can do an IgE inhibition assay, which is very hard to do and long-lasting. We could do a BAT. We could do molecular allergens. If VESV1 and VESV5 are negative, there is an unlikely cause of Vespid venom allergy. If all is negative, we can check the value. If the total IgE is low, we could combine the tests. We can do the BAT, or if all negatives, we should consider non-allergic reactions. Last words, methods for predicting with success failure need further investigation, in my opinion. And don't forget the patient history and tryptase. Thank you for your attention.